There's certain patterns that for sure we become accustomed to seeing that we look for, but I think we look for those patterns with the mentality, the mindset, the precursor to this could very well deviate, and I have to be able to adapt and pivot my treatment. And I think that's a summary for life, is that we have to be able to adapt and pivot for
ever.
The nuggets that I get for helping somebody to heal come from asking them, tell me a story about how this started for you.
FSM teaches you flexibility of mind. You have to treat what you find in real time. Yeah. And you're rewarded because it works.
This is a part of healing. Nothing you have scares me. We're going to handle everything that comes at us together. We're a team.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
Hello.
Hi. We're early. Wait, is this like opposite day?
We're black and white and we're starting early. I just had that feeling to get here as fast as I could.
I always have that feeling. I always work out. That little heart on my t-shirt.
I see. It's so cute.
And that's my
it's a Snoopy
t-shirt.
That's a Snoopy.
Yay.
Aww.
Oh.
And you're back.
I'm back.
Hey.
So we are doing the core seminar this week.
You are.
We are.
Yes.
And it's been really fun.
Of course it is.
Yeah. It's always so fun to watch the journey of discovery, where the physical therapist who's been in practice for 20 years goes, it just disappeared? Yeah. Oh, yeah.
I think that moment, the ahas that you get to have over and over again, I think that's one of the reasons why I hear that this podcast is so valuable to the clinicians that listen. Hearing you having that aha, that surprise, that I can't believe this worked. I can't believe this worked so fast. Having that, what is that? It's not surprise, it's not disbelief, but it's what is it?
It's someplace between the surprise and it's not disbelief exactly, but
no,
you know it's going to happen. And
you have to go into that treatment with that confidence that it's going to happen. Otherwise, you would never get anything accomplished, I don't think.
But on the other hand, it's always amazing when it does happen. So one of the practitioners at the seminar has a daughter who has spastic diplegia. And my immediate response was, oh, goody. Wait, how old is she? 20s. I said, that's easy. And then I go, well,
yeah, can't say that.
It always has been. So it should be. And this is what you run. And then it lasts for 2 weeks. And since you're forcing the body to secrete GABA, you have to provide the precursors to GABA, which, yeah, sure, it's not that hard. How do you do?
I know. And like I said, I think if we got really good at something, you would think that it would become mundane and boring. And I hear that a lot about people who change professions, where things get boring and predictable. And that can literally never happen in an FSM world.
No, it's never boring.
It's never predictable either. And the twists and turns that the river takes us down. So I'm
Well,
grateful to FSM for that because before FSM, I was not very pliable in my thinking. I wanted a formula, I wanted an algorithm, I wanted metrics, I wanted everybody to behave a certain way. Do you know what I mean? And maybe that was just being young and green also, that you think everybody's gonna just follow that healing trajectory, and then you get in the real world and it doesn't happen like that.
and that was the other thing I got to say yesterday was the medical education teaches you attention to detail. In
Yeah,
order to get into medical school, get into some PT programs, PA, NP, whatever,
yeah,
you pretty much have to have a 4 point. And the only way to get a 4 point is attention to detail.
yeah,
You learn that. And FSM teaches you, takes advantage of that platform because you have to pay attention to detail and diagnosis and what you feel.
yeah,
FSM teaches you flexibility of mind. You have to treat what you find in real time,
yeah,
and you're rewarded because it works. And that's the only way it works. And you tell people in the course, okay, these practicums are systematized, formulated, predictable. It's the cervical spine,
yeah,
supine, and it's going to be the same until it's not.
yeah,
And then, but most of the time, this is what you get.
yeah,
So we had an Ehlers-Danlos patient or hypermobile, HEDS, and she, of course, had a vestibular injury. So when they treated her for the hypermobility, I think it was before or during the first part of the class, they had 124 and 77 to make the connective tissue normal length. Then they had 40 and 10. She said, my feet always kill me. It's like, oh, that's your spinal cord. And she went, excuse me? I said, it's your spine. And your elbows? Yeah. And my shoulders? Yep. Hips? Yep. Knees? Yep. That's your spinal cord. So we did 40 and 10. And then I felt her legs and went, oh dear. Okay. So we need another machine set up for 81 and 10. Why is that? Because you feel how tight your legs are, and then everybody came and felt the tone.
yeah,
That's loss of descending inhibition, and we can fix that. So that's 81 and 10. And then I put the tuning fork in the middle of her head and did fields of gaze and lateralized to the left, saccades to the left. It's like, okay, we can do that too. So we did 40 and 44, quiet the inner ear. And in 60 minutes, she stood up and it was done. And it's just, okay, I like it when it's predictable. And some of that stuff is from the advanced.
yeah,
We've moved a lot into the core,
yeah,
but so they were treating somebody's cecum, lower right quadrant. And I went, And I said to the tableside assistant, can you look at the frequencies for parasites from the advanced?
yeah,
Because that's usually the thing that makes the cecum unhappy. And sure enough, this is first grade through maybe third or fourth grade, sixth grade. And then the advanced is middle school. And
yeah.
then the advanced plus the investigational frequencies are the rest of your life.
The questions that we get to ask during a treatment as clinicians, it's funny, the conversations that we get to have, the connection that we get to have. I've slowed down my practice so much because I really want that one-on-one, slow down interaction Because I just think we crave that right now with where we are as humans in this world that we live in, to slow time down for somebody and to be able to take away their pain and to ask questions that invoke stories. And I think
Oh,
so
yeah.
much of the nuggets that I get for helping somebody to heal come
Mhm.
from asking them, tell me a story about
Really?
how this started for you. Tell me this story about your athletic history. And instead of saying, when did the pain start? When did this start bothering you? Because you get these quick kind of choppy answers. But if I say, we've got 90 minutes, tell me the story of whatever. I'm hearing about the trips. I'm hearing about the parasites. I'm hearing about the food. I'm hearing about the relationships. I'm hearing so many different
Mhm.
nuggets
Yeah.
that I will jot down as, could this be the could this have been the catalyst to when it all started? Very similarly to the story that you tell in the core with the women and the bunny slippers in the robe that takes out the trash. Those stories, though, are what makes patients put two and two together. It's not just run this for that, because I don't
But
like that.
it's the nuggets that let the practitioner put it together. So there's a piece of my brain that goes, it couldn't possibly be this easy. And you run,
Yeah.
what was it, the emotion
Yeah.
and the fact that she had a cold, a flu. And it's like, it was that easy.
I think how I've been phrasing it lately is, when I get that result that's really quick, when I do want to say it can't be this easy, is,
Hmm.
wow, we're getting really good results right now. I'm not sure how long they're going to last, but this is a really great way we can start.
You're
And
so Canadian modest.
I
That's
know.
all.
Well,
It's so cute.
I've learned with athletes that
Hmm.
you can't overpromise and
True.
underdeliver, right? I do always think it's the safer way to go to be in real time, because sometimes we don't know how long it's going to last. And
True.
we talk about those cases where you take the pain from the 9 to a 2, but then it comes back and they mind it more. And there's more layers to that equation because they've been out of pain and now they're in it again. So I think if we kind of temper with, this is really good right now. I'm not sure how long it's going to last, but we have tomorrow and the next day, and we have the next 8 appointments lined up, and you've got a custom care, and we're going to troubleshoot that together. I feel like those phrases, you can just see the tension. It's like that balloon that's about to pop, and you just let the air out a little bit, and there's, oh, okay, the pain is
Okay.
down. And if it comes back, we have a way of dealing with it because we did it once and we can do it again.
Yep. And instead of saying it might come back,
Yeah.
my language is your pain level's a 1. If it comes back, it's not going to be any worse, but you're going to mind it more. And that is
Yeah.
like if it comes back.
Right. Right.
So that
Yeah.
lets, it's the same as saying, I don't know how long it's going to last. And it's like, what we did right now should last about a week
Yeah.
or 2 weeks or forever. I'm
Yeah.
not sure. But if it comes back, I, it's like it might come back.
Yeah, and we know that words are important. Specificity is important, intent is important. And so when I'm asking people about, tell me this story, I want to hear kind of those words like unfiltered and raw, because I think you get more accuracy that way. It's funny, I've been traveling around with my Dr. Codman's book quite a bit.
Oh my goodness. Of
And
course you
it's
are.
quite magical. And it's a book that I have not read cover to cover, but I just feel inclined to open a page and read it. Now, this was first published, the original edition, 1934.
Oh my.
And I have to tell you, the words that we have a lot of our frequencies from, like hemorrhage and trauma, and what's another one that he writes about? It seems like very dramatic, but he's talking, one of the pages that I had just opened to in between patients last week was about a fracture of the lesser tubercle of the humerus. And he talks about how the man fell. And that's the thing, like, you would
Oh,
never read a textbook a medical textbook and hear the story of the history, the way Dr. Codman
Exactly.
cared about. He talks about this very intelligent man. He uses these adjectives and adverbs of the patient. And he says this is not the patient that would exaggerate his symptoms. So I really believe he's in a great deal of pain. And
Oh, wow.
and his presentation doesn't match his pain. And so he keeps digging layer by layer, does a different x-ray view. And then he sees this fracture that he would have missed before because he cared so much about
Because he
matching up
listened.
the pain to the diagnosis. And we talk about this all
We
the time,
do this all the time.
all the time.
Codman is one of us.
It gets better.
Oh,
He
good.
talks about how physical therapy will not help this man, but massage and diathermy will.
Okay, then.
So, to those of you who are listening, diathermy is electrotherapy.
Yeah, it's hardly ever used because you turn a diathermy machine on in one room and it heats up the patient in the room next door.
But could it have been a term that he just used for maybe microcurrent, maybe
It's
different
heat.
machines?
Oh,
Like,
it's heat. It's heat. Diathermy is, I think it's the wrong electromagnetic field. They had a diathermy machine in chiropractic college, and none of us learned to use it because it's so dangerous. It's, oh yeah, we don't do that anymore. But
no, but I'm just thinking for those practitioners, like, could he have been in trouble for writing about microcurrent because these machines were,
oh
do you know what
yeah,
I mean? Maybe this was the
yeah,
workaround.
yeah. It
Right?
could,
I don't know. It's just so interesting. So, for those practitioners that like to geek out, I implore you to try to find books from the 30s and to just listen to, if anything else, how orthopedic surgeons were taking history.
yeah,
And
because surgery was such a big deal back then.
yeah,
Now it's just an ICD-10 code, and what we get most of the time are surgeries they didn't need in the first place. Back then, they knew the risk,
yeah,
or they seemed more aware of the risk than they. Speaking of Codman and
yeah,
shoulders,
yeah.
patient came in this week because I didn't tell you about her last week,
No, I was,
and she said, "I have an acute," and she's one of my favorite all-time patients. And so she came in and I had this acute frozen shoulder. And I went, okay, let's see. And she could literally abduct it 20 degrees and couldn't move it in zero internal and external rotation. I said, what'd you do? I didn't do anything. It doesn't come from space. 3 days before the pain started, I was using a leaf blower. I had a pack on my left arm, and it's a right arm that's painful. And I was just using a little, and if you look at the motion, it's internal and external rotation. And it's like, okay, subscap, infraspinatus, lift it up, supraspinatus. Okay. So I felt her shoulder, and we ran torn and broken on the flat tendons, round tendons, torn and broken in the labrum, inflammation in the bursa, forwarding. I think I have 6 machines on her. And then when I went she brought her custom care and her converter. I went to reprogram her custom care, and everybody should know once a patient leaves, it's out of my head. Some of that is a vestibular injury, and some of that is if I remembered them all, it would make me, I don't have enough RAM. And I looked at it and went, you have Ehlers-Danlos. You're okay. Number one, no more using leaf blowers. You can't do that. You're not allowed. And you have partial thickness tears. And so that's what we ran. But I didn't remember about the hypermobility until I went to make sure and put a shoulder repair protocol for overnight on our custom care. And that makes sense. So we took the shoulder pain protocol, and instead of that one, we added shoulder injury. And I spent more time on the labrum and on all the tendons and made it last till did cut and paste or copy and paste until it was a 6-hour overnight program. And at the end of it, I showed her the Codman's exercise. You want to distract it, and you do this, put this much water in the bottom of an empty gallon jug, and you swing your arm by bending over and moving your body. And at the end of it, she had her arm up like this and her pain was gone. And I said, you have technically a frozen shoulder, but it's not exactly frozen. You've stretched and injured a bunch of tendons.
Right.
Yeah. That's the aha.
It is the aha, and it's patient education, and even clinicians will come in attached to a label, and especially somebody with the term frozen shoulder, because frozen shoulder can mean years of immobility, right? And so clinicians and patients.
That was the other thing. They were going to do a steroid shot they were going to ultrasound and diagnostic ultrasound, find the joint, put steroids in it. And I said, it's a little problem with that. And that is that steroids make connective tissue weaker.
Yeah.
And you don't have an inflamed frozen shoulder. She's not diabetic. She doesn't have any inflammatory, autoimmune, anything. You have at least 3 partial thickness tears, and they're going to do the steroid injection without doing an MRI first. Okay. So
I can now comment on these things because of the clinic that I get to play around in. And
yes.
We don't even do steroid injections. No. People ask for them all the time. And it's a lot of patient education of just saying what you just said. It breaks down the tissue. It's not worth. We can do other things.
It's not worth the risk.
No.
No.
We want healthy connective tissue, especially in a structure such as the shoulder, whose complete integrity, I don't know who designed it, but there's multiple flaws with.
We should have a conversation when we.
It is on my top 5 list of conversations to have. Excuse me, we need to redo this. Why was I not consulted with this?
And it's one of the things I loved about having Dr. Reynolds lecture. He said, when he says, whoever designed the shoulder has got to be, we need to have a conversation.
Yeah. And that's part of that is having the adaptability, the flexibility of thinking to say, yes, I understand maybe historically we inject a joint with this to take the pain down, but that's not looking at the big picture. That's not looking at holistic health. Sometimes that big picture, those steps take a bit longer to get to, but I have found that if patients have a mindset that these little hiccups in rehab, and I don't want to even say setbacks, I'll say side steps, like that trajectory that I thought everybody was going to fall on when I was in my 20s practicing, when they improve and then something happens and then the pain goes up and it's like, these things can happen. This is a part of healing. Nothing you have scares me. We're going to handle everything that comes at us together. We're a team. Even those conversations can be so helpful for the patient to know that they're not in it alone and that these side steps are normal and it's not always linear.
And if they understand why.
Yeah.
So you had this sidestep because it's like you had this remember what you came in with 2 weeks ago?
Yeah.
Because of that, your body decided that it needed to do this.
Yeah.
And now that it doesn't need this anymore, that happened. Oh, so we'll just fix this and that. And we already fixed that. So that's not broken. That's not back.
Yeah.
But these two, do you see where they came from?
Yeah.
Oh, okay.
We had a patient a while ago who had an ACL reconstruction, and this was probably 2 years after that reconstruction, was doing an exercise called Nordics. I'm not sure if you're familiar with it. They're a pretty controversial exercise. It's a hamstring exercise where you're in a bit of a contraption, seated, prone, so your feet are locked in, and then you flex at the trunk, and then you extend with your glute and your hamstrings, and you come up. And so people do it on devices. They do it by themselves on a mat with people holding each other. Anyway, she felt a pop on the back of the knee and thought that she blew her graft. And I can understand that fear, especially when you have a catastrophic injury and a repair done and you get pain in the same location with a perceived pop. So but didn't have a whole bunch of swelling, could walk, but just freaked them out so badly. So a little bit of imaging, diagnostic ultrasound showed everything was fine. And that little pop was probably a piece of scar tissue, could have been fascia. There was no bruising, no swelling. And then it was amazing just seeing that the graft was fine, functional exam was fine. The pain starts to go down. I'm like, oh, it's actually feeling better. And then explaining, yeah, you had some scar tissue back there. It happens. Popliteus sometimes becomes dramatic. Those are small muscles. And then take it easy. Don't ever do that exercise ever again. It's not worth it.
Yeah.
And those trainers that are listening to this podcast that love Nordics, we can have a conversation. I'll go toe to toe with you. I just don't, I see the bad side of those exercises, not necessarily the benefit sometimes.
You have to see I can't even visualize the position you just described, but
Yeah.
I can tell you what you described. It doesn't sound good. It
You have
sounds
to have
safe.
very strong hamstrings and glutes to do the exercise. I think once upon a time, it was just bodybuilders that were doing it, and then the athletic community started doing it. I started seeing an increase in injuries because of that exercise. It has to be done with assistance, with the trainer, with somebody that can see when the form starts to break down, when to stop. Like so many exercises out there.
Yeah.
Just saying.
And yeah, yes, there we go.
Yeah, I don't know if we have any questions yet, but I try
We
to
have
check in.
this.
We have our cochlear implants contraindicated if you remove the external transmitter.
Cochlear implants are pretty uncommon. They're an artificial auditory implant. It's for people that completely lose hearing.
Okay.
I guess it depends on what you're treating. If you were to remove the external transmitter, there you go. I didn't know they had an external transmitter. If you remove the external transmitter, I can't see why there'd be any problem at all. And even
Mm.
with the external transmitter, I can't. Okay. And then somebody tell me what charge syndrome is. So, Suzanne, how is it that these people find you? Good heavens. So I would imagine it, it would not be a problem, especially if you remove the external transmitter. You're not ever running current to the brain anyway. And as long as you're treating below the neck, it should be okay.
Yeah.
Did I tell you about? No, because we had the podcast on Wednesday and the patient with SPG7 was doing more or less fine until Friday. And she came in and she said, my right leg isn't working. SPG7 is a mitochondrial defect where the SPG spinal P stands for peptide gene. Anyway, my right leg feels heavy. I'm not moving it.
And I just Googled it really quick. Spastic paraplegia type
Paraplegic
7.
type 7, and it's spastic paraplegic gene.
Yeah.
And she didn't get it until after she got COVID.
Okay.
So we have our approach in the beginning. It's in general, the SPG gene is expressed primarily in this. And then, so we treated the brain mostly the first 2 or 3 times she came from Texas. And then it moved down into the spinal cord and the nerves. And then it moved into the mitochondria. The condition didn't move. What we needed to treat moved. And so we treated the mitochondria, have an ACE2 receptor. So the mitochondria we treated for the COVID frequencies. And there's a frequency for, and what happens in SPG7 is the peptide, spinal paraplegic, there's a peptide that is formed that's misfolded. So it's folded wrong, and it's like when the dirty laundry gets mixed in with the clean laundry. So you have these misfolded neurotransmitters or peptides that are clogging up the works. And we have a frequency for excess proteins. And one day, about a year ago, I thought, I wonder if 120 excess proteins would be helpful. This is a perfect patient because she just falls asleep. When it's correct, it's like she's out. And on Friday, she came in with, my right leg doesn't work. Great. Okay. So we went back to the cerebellum. And then I have all this list of spinal and brain parts and spinal cord pathways that I had no idea. It was on George's experimental list that I didn't know what they did. Just, oh, okay, fine. So I started searching while she's passing out. And there's this connection, a factoid, that the peptides that create movement go from the cerebellum by this one particular pathway that George has a frequency for that goes to the medulla. So they doesn't go directly from the spinal cord, from the cerebellum to the spinal cord. It goes by this pathway to the medulla. So we did the cerebellum, we did this experimental pathway. She passed out for close to an hour. And then we did the medulla, and she also slept. And then he had a descending motor pathway whose name I forget, the vestibular something, and it coordinates movement and balance in her gait. And that knocked her out. So the 2 frequencies we used are from the advanced. One is repaired DNA, 528, and the other is misfolded proteins. And when she got up off the table, basically 2+ hours later, she walked completely normally. She has to lock her knees, but the foot drop is even gone. And it's like, okay then. That was interesting. How's your right leg feel? Light, it works. I'm good. Okay.
Wow.
Okay. And I'm working off a list and a internet search for what these pathways do. I don't even know what they are, but I have this list. Ben Catholi probably knows what they're for, but
yeah. I think sometimes those pathways, whether it's what you're talking about or something else, sometimes that's what we miss when we're coming up with the hypothesis of what tissues are involved and what pathology, but the connection from A to B or from skin to muscle, like what's in between that? What is the pathway? Not even just from a nervous system perspective, but from a structural perspective. What is it?
yeah. And if you're willing to ask that, you can do almost anything.
Yeah, I have two stories quickly. One, remind me to ask you about the contraindication list because people seem to be all over the map with our contraindications and I don't know where it's coming from. But so along the same lines, we have a patient who has a history of some knee issues from just being a very active person his whole life. Bumps, bruises, fractures, meniscus issues, and had a Baker cyst that was aspirated, and now that's fine. But there's a cyst-ish structure on the lateral side of his leg near the fibular head. And at the clinic, person that saw it's not really sure. It feels like it's subcutaneous, can't aspirate it, doesn't think that it's causing the hip and knee pain or that this person has. And I'm like, that area is such a hot spot for it's from an attachment perspective. The lateral knee is everything. We have the ITB, we have ligature, we have the peroneals. It's everything. And so when I'm having these conversations of when somebody is saying it's not really a muscle, it doesn't really cause anything. And it's like, no,
but the pes anserine and the hamstrings and the nerves and the everything.
Yeah. And if you look at it just from, I always just call it the princess and the pea. So you might not think that it's this big structure that needs surgical intervention. However, if you have somebody that's especially so athletic, that is so dialed into any sort of deviation in the fabric of their fascia and their connective tissue, and you have a cyst there, and that's creating tension. And then the other part of education wasn't just with my fellow clinicians, but it was with the patient who was told his whole life to just keep rolling his IT band. And
Okay,
there are still some people that love to roll the IT band. And I have to tell them rolling can be really great for vascularized tissue. This is a hill I will die on. Come at me, anybody that likes to roll the IT band. And those of you who have taken the sports course know that I have 2 slides all on the IT band, the constitution of that tissue. There is no, let's all say it together, even for the people in the back, there is no actin and myosin in the iliotibial tract. It is dense connective tissue. It is just guide wire, right?
Yeah.
So the IT band, you cannot physiologically have a tight IT band.
No. It's contractile. It is not.
It is non-contractile. It does not have actin and myosin. It cannot shorten because it is not a muscle. It is a band. So patients that are listening, you can't have an IT band because it can't contract. It cannot shorten. What can shorten is the TFL, which is the tensor fascia lata. That is the muscle on top of the IT band. So the TFL, tensor fascia lata, that can get tight and that can create tension and feel like the IT band is shortening, but it's not. It's just the muscle that's on top.
The only thing you can do to the IT band by rolling on it is tear it.
You compress it, right? And so rolling, just like some manual therapies, is all about what happens after the therapy, right? So if we do an ischemic compression, the magic is in the word ischemic. If you roll it, you compress the tissue. And then the idea is once you're done rolling or once you're done pressing on tissue, the tension comes off and then you get reflexive hyperemia. But what happens is with the IT band, when the reflexive hyperemia comes in, it doesn't get absorbed because it's not this vascularized contractile tissue. It's dense connective tissue. So then you get that inflammatory response happening underneath. It has nowhere to go. And then what happens? You get more adhesions. So it's a great business model for the foam rollers because you never get better.
Good point.
So from a business model perspective, yeah, the foam rolling people will, because that's the first thing I get on the foam rolling diagram. It shows to roll the IT band, right? The foam rolling people never want you to get better. They want to just keep selling you different types of foam rollers. But I want to get you better. So we stop rolling the IT band. If I'm a big proponent of rolling, but roll the big juicy vascular tissue and do some other stuff before and after you roll. Sorry, that just takes a lot out of me.
No, it's just get it out. It's cheering you on.
But part of that is just patient education, right? So when I'm telling this person, I think a lot of the knee pain could be from rolling the IT band because that has to pool somewhere. And when you look at the lateral knee, look at the knee in general, just with all the vessels and the nerves. The biggest results I've had, my breakthrough moments with the knee this past year, especially, has been treating the fat pads. That is the magic bullet. That is the secret sauce. That is the tissue that nobody can treat because it's the fat pad, but it's undeniably problematic in people.
Yeah.
97 is the fat pad. And it's more than just 3. I'm telling you, it's more than just 3. The adipose can have trauma. It can be bled onto. That's the other thing with Codman's
It's
book.
inflamed.
It gets inflamed. I've been playing around with torn and broken. I don't know if adipose tears the way it's supposed to, but I feel like there's something to that pattern that can be useful. Kevin just take a picture.
I think he did.
But again, with Dr. Codman's book, he talks about the blood pathway. So he's talking about this bruising that happened with this man's arm, and he was following it along this brachial plexus through this space, through the bicipital groove.
Wow.
And that to me is all about 18 because it's not just a acute something's bleeding frequency or you have this bright new brand new bruise frequency. It is definitely apparent in those like chronic conditions where you have this pathway of just think about if you hurt your leg and how you get that bruise that happens on the ankle where everything just kind of pools in pockets and sits. That's all 18. That's following 18 all the way through.
And every place there's a drop of blood, there's scar tissue. That's how treating the psoas. So teaching this group, why are we running 13 and 60 to treat the psoas? Because the ureter is adhered to the psoas. How did it get adhered to the psoas? In an awful lot of cases is because you got hit in the back. And all it takes is one drop of blood running down between the ureter from where you bruised, running down between the ureter and the psoas. And it's, okay.
It makes sense once you unpack it, right? And I think the phrase is if the tissue bleeds or if it's ever been bled onto. To me, that phrase changed everything because you would think that doesn't really bleed and that tissue doesn't bleed, but bleeding happens and it happens into all those tissues.
Road rash.
Okay, quick contraindication clarification time.
Okay.
And I don't know if these are rumors that float around on social media or Facebook.
No, it's going to be the Facebook group. There's a few people on there, and I can't do Facebook anymore before I go to bed because I'm not allowed.
Yeah.
Not allowed to look at my phone.
I rarely go on Facebook, but I'm just assuming. So we do have contraindications, right? We talk about pace-dependent pacemakers. That's usually the one that I see the most often in the clinic, pregnancy. And not that we know anything with pregnancy. I treated people while I was pregnant. So, and for all intents and purposes, that's me snacking off the current while I was pregnant. My kids are all normal for all intents and purposes.
Yes.
They're all doing quite well in their life. So and because there's obviously some patients who don't know that they're pregnant at the time of getting treatment. I don't think we've ever heard of anything, but that's just.
The thing is it's covered in the core. There are slides.
Yes.
Cover it. So we've never had a problem, but the TENS devices can't be run through a pregnant uterus. FSM has an additional contraindication because, number one, 40 hertz reduces lipoxygenase and cyclooxygenase, which are prostaglandins. There are certain prostaglandins that are required to maintain a pregnancy. So when we run 40 hertz, there's no guarantee we are only going to reduce the prostaglandins that cause your back pain or cause your whatever, bursitis.
Yeah.
We might be affecting something else. So let's not do that.
Yeah.
It's,
Yeah.
you've got 7 months and I'll bring the baby in, we'll treat both of you, but not treating you once I know you're pregnant. Once the patient is known to be pregnant, don't treat them. The other thing is when a patient gets stoned, when the patient gets all floaty and loopy and their endorphins go up by a factor of 10 times, for the adult, that's a very pleasant day, a nice night's sleep, and the next day they're fine. For the infant, during certain critical periods of fetal development, the brain, parts of the brain are setting the threshold for how much endorphins, let's say, it takes to make this nerve fire and say, I'm happy or I feel good. And if that huge spike in endorphins, because I don't know how long, I don't know that anybody knows how long it takes for that threshold to be set. If it's set over a 2-week period, it's probably not a problem. But because I don't know, if you have one day in which that threshold is set and you give them a spike of endorphins that lasts 6 to 8 hours, you can have a lifelong effect on that fetus. That's not okay with me. It's like anybody that does FSM doesn't get to do that on my time. It's like, no. So that's where the pregnancy contraindication comes from.
Yes.
Once they're known to be pregnant.
Keep going with contraindication.
Okay. Demand type pacemakers.
Yeah.
Never had a problem. And I have actually run current through the chest of a patient I was treating his asthma. And I said, what's that little scar? And he said, oh, that's my pacemaker. Yeah, that was exciting. And basically, if you're going to treat somebody with a pacemaker, we have one practitioner who brought in the rep from Medtronics, had them put a monitor on the pacemaker, and the frequencies and the current not run through the chest, but just run on the body, do create an artifact between the heart and the pacemaker. So there's an extra input to the pacemaker circuitry. And their conclusion after they played with it that day was if you run it above the clavicle and at the waist, you're fine. Probably also applies from neck to feet. And pacemakers have a low end and a high end. You're not allowed to go below 60 and you're not allowed to go above 120, 100 and just depends on the patient, how active they are. So that's one. Infection, especially encapsulated infection or a cult infection. If you know you have an infection and you run 40, FSM will shut down inflammation even in the presence of infection. And while the inflammation is down, the infection has 2 to 6 hours to proliferate. It just gets worse.
Yeah.
Then when the 40 hertz wears off, the pain's worse, the infection's worse. So in the presence of a known infection, don't run it. On the other hand, if you have an occult infection, an infection you didn't know was there, so the story about the lady with the pins in her thumb and the red swollen thumb, normal. And I said, if it's infected, it's not infected. I had an x-ray on Monday, right? But if it's infected and that infection didn't show up on the x-ray, when the frequencies wear off, the pain's going to come back and it's going to be worse. And you are to go to the emergency room or urgent care and get antibiotics. So that particular precaution
Yeah.
is more, it's actually good news. I freaked out when I saw somebody say, oh, I'm never going to run 40 because it can make an infection worse. And it's like, no, you missed the point.
Yeah.
An occult infection is an infection you don't know about. If you use 40 hertz and all of a sudden your tooth flares up 2 hours later, you know that tooth is infected. You mean it's diagnostic? It's, yeah, pretty much. And spinal stenosis, it just means you have to run an alternating current.
Yeah. I've treating a lot of people with stenosis just fine.
Yeah, me too. I treat them all the time.
Yeah.
It's just, and in the course seminar, we use everything alternating.
Yeah.
Because we don't have physical exams, we don't have histories, and we don't have imaging. And we're doing practicums on everybody.
Yeah.
So it's a thing.
So 2 other ones popped up on the
Whatever.
Insulin pumps.
Oh, insulin pumps, spinal cord pumps are easy. You just turn them off. Baclofen pumps don't have an off switch, but we've never had a problem with them.
Yeah.
Insulin pumps make me nervous.
Yeah.
Because while they are shielded, they're all shielded from EMF and electrical signaling. But insulin pumps, not only do you turn them off, if it's possible to unplug them from the insulin reservoir, do that. Because if by some fluke the frequency has the capacity to increase the amount of insulin that the pump is going to put out, theoretically, you should be able to turn the pump off and it's fine. But if the frequency has the capacity to make the pump put out more insulin, that is really risky to the patient. So yeah, that one's a real one. That's somebody with an insulin pump is a thing.
Yeah. Good. Okay. And then one that I know we have a case report on treating, but was lumped into the contraindication was DVT.
Oh, we just don't run 284 in the presence of a DVT.
Right.
Because there's a blood clot and 284 we know dissolves blood clots, but in a DVT, there's no guarantee the blood clot's going to liquefy all at one time. You're going to break off chunks, maybe, and first do no harm. So then we have Jessie Tierney, who presented her case report on a DVT with a positive D dimer. She treated the patient one time and for torn and broken and vitality, right? Vein?
So, yeah.
The vein. I'm not sure she ran secretions in the vein, but that I think is maybe possible.
Yeah.
And the ultrasound was negative the next day and the D-dimer was negative the next day. And that's not possible with anything. So the only contraindication with the DVT is don't run 284.
And when after they've recovered from the DVT, even if their leg is still inflamed, I still would avoid running 284, but you can go ahead and treat other body parts and
you can run 40.
Yeah.
Basically, I have stopped using 284 for chronic inflammation.
Me too.
There's
other things that just work faster and better and are more relevant, I think.
Yeah.
Yeah.
And
I think, and then tachycardia.
What about it?
I think that's floating around too, that it's contraindicated to treat people with tachycardia.
It depends on how bad the tachycardia is, under what circumstances it happens. So if they have supraventricular tachycardia, which is basically atrial tachycardia or atrial fib, that's increased secretions in the vagus. So you can bring down tachycardia by increasing secretions in the vagus. We've done that before. But for almost everybody in our practitioner base, we have two cardiologists worldwide, that maybe three, that use FSM. And for all the rest of us, if a patient has POTS, that's easy. You just treat the vagus and the POTS goes away. That's good. But for every other cardiac tachycardia, it's outside your scope. So FSM isn't going to make it any worse. But you take the pulse, and if it's 150, yeah, you allow me to drive you to the emergency room.
Right.
Or urgent care. It's outside my scope. Speaking of which, FSM practitioners pay attention to detail. And I had a patient in last week or the week before where he's being treated for postural hypotension. So he goes from sitting to standing and his blood pressure drops. So they sent him to a nephrologist, okay, for his hypotension, postural hypotension. It's a strange choice of specialty, but that aside.
Yeah.
And this doctor was to check him for hypertension, elevated blood pressure, and this low blood pressure phenomenon when it goes from sitting to standing. And they put a Holter monitor onto him, except that it was for blood pressure. So we're a constant blood pressure cuff for 1 or 2 days.
Okay.
And it took his blood pressure about every 20 minutes, which is okay. And he said the doctor just went over the graph with him. And I looked at the graph, great. But then he had 3 pages of numerical data that was blood pressure readings for 2 or 3 hours in a row during the day. His blood pressure was 210 over 150, 220 over 140. And I lost it. I said, did your doctor go over these? You're an intelligent person. He was a professional, not a medical professional, but it's like, do you see these numbers? The ones that I've highlighted in yellow? And most of the page was highlighted in yellow. In the middle of the night, he had a blood pressure of 210 over 145 for 40 minutes in a row. I said, you have sleep apnea at night and you have hypertension in the daytime. I'm going to make a note in my chart notes that says I have noted this, highlighted the pages, told you to consult your medical physician. Why would you do that? And it's like, because that way, if something bad happens, then it's not on me. It's on the person who should have told you this.
Yeah.
It was really interesting. And working on him with concussion in vagus or vagal tone, okay. But it was interesting. Yeah, he had head and neck radiation, and the radiation fibrosis went really well. He went from 20 degrees of motion to 70. So that was good.
Yeah.
But yeah, okay. Sorry.
Wow.
Could
Yeah,
talk about getting us off track, but
no, it's not. These are all stories I think that are just good to share for everybody listening.
let's, even for the patients, what I would encourage you to do is remember that your doctor works for you. and that you are allowed to look things up. And you're not telling your doctor what to do, but it is just fine to ask them, can you tell me about this? They might get mad at me.
I know.
And then what will happen?
Right.
Oh,
Yeah, and I think that is an important. I'm always telling people to get second and third and fourth opinions. I'm like, if it doesn't feel well or sit well with you, keep asking. There's a reason for that. And best case scenario, all four doctors say the exact same thing, and you can rest assured that you've done your homework. I think that's it. It's 4 o'clock.
wow. Amazing.
I will not be here next week. I will be working with some hockey players up in Canada.
Oh, lucky you. That'll be so much fun.
It's part of the summer. The fun part of my job is this next week. So I'm excited about it, but I won't be here, but I'll tell you all the stories the week after.
Oh, goody hockey stories. I love hockey stories. It'll be fun.
Yes, it will.
Yay.
Okay. And if that's it, then we will see everybody. You'll be here, I'm sure, but I will see everybody in 2 weeks.
Everybody will help put on the podcast next week. They're always great at asking questions and keeping me.
Yeah, and I can send you the list of the proverbial list that keeps coming here too.
Okay.
Then you'll have stuff to answer. Okay. Bye, everybody.
Bye, everybody.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.